and it found.
Sorry about that.
It's okay, sorry. And it found different results from the ITT and PP analysis. So just a bit background on gastric cancer, which is not a very prevalent cancer in the US, but it is the 6th most common cancer worldwide and the 3rd leading cause of cancer death. So gastric cancer is most prevalent in East Asia. It is estimated that almost half of the world's gastric cancer cases and deaths occur in China, which is one of the reasons that my previous work was mainly focused on this disease. So nowadays, the treatment of resectable gastric cancer or locally advanced gastric cancer is a comprehensive approach, and which includes surgery plus perioperative treatment. And this treatment modality differs by regions. In Europe, the standard is to treat patients with perioperative chemotherapy and surgery. In Asia, surgery is the key, and patients will also receive post-operative chemotherapy. In North America, the standard is to treat patients with surgery plus post-operative chemoradiotherapy. So all of these treatment modalities were based on several large international clinical trials. And the investigators of this CRITICS trial think it may be of interest to compare the European standard with the North American standard and to see which one is superior. So that being said, this CRITICS trial is a trial of comparison of 2 treatment modalities. The control arm is the European standard, which is perioperative chemotherapy plus surgery. The experimental arm is the North American standard, which is preoperative chemo plus surgery plus post-operative chemoradiotherapy. The investigators treated this North American standard as the experimental arm because it was hypothesized that this extra of radiotherapy would improve patient survival. In 2018, the primary results of this trial was published in Lancet Oncology. Now let's dive right in. First, study population. So which includes inclusion and exclusion criteria, and here are the major ones. For oncological trials, the most important eligibility criteria is basically the cancer stage. And here for this trial, it was stage 1B to 4A. And also the authors mentioned in the exclusion criteria that patients with T1 N0 tumors. So T is the tumor death and N is the lymph node status. So patients with this tumor would be excluded. So not this is a question, but this is the part that confused me. So I was wondering if anyone here today could share some of their opinions or experience with this. So from my understanding, the exclusion criteria shouldn't be just the opposite of the inclusion criteria. But here, actually regarding the tumor stage. So as I just mentioned, the inclusion criteria is stage 1B to stage 4A. And the first exclusion criteria is actually corresponding to stage 1A. And they are mutually exclusive. So I was wondering if anyone has encountered similar situations like this before, and why the authors mentioned this in their eligibility criteria, like in this way.
I'm sure
will.
someone with more, sort of experience with actual trials would be able to give a, other answer from their own experience and stuff. But I mean, from what I see, it's pretty common that, exclusion criteria are just the opposite of inclusion criteria, which is why it's better to just refer to the whole section as eligibility criteria, where you've then got, you can sort of say everybody meeting these elements fits, they're eligible, as opposed to trying to explain inclusion and exclusion, because they are often they're often the opposites of each other. If you're including adults, then you're obviously excluding children, that kind of thing.
Thank you, Reyes.
I was only going to say that I have been guilty of this, and it's almost not something that you kind of, I think it's more about stepping back, and I think Reyes has a really good point about just saying eligibility criteria, because when you're in the weeds, everything looks like a weed.
Yeah, thank you, Dr. Halbrecht. Okay. Now let's move on. Okay, treatments. So as mentioned above, there were two treatment modalities under comparison. The control arm is perioperative chemotherapy plus curative surgery, and the experimental arm is preoperative chemo plus curative surgery plus postoperative chemoradiotherapy. We can see from this graph that up to the point of postoperative, the two groups were treated with the same treatments. And the difference was actually in the postoperative phase, where in the control arm, patients were treated with 3 cycles of ECF regimen chemotherapy. So that's a total of 6-week chemotherapy. And in the experimental arm, patients were treated with 5-week chemotherapy of the same regimen plus 5-week radiotherapy. One thing that jumps out about this trial is the timing of the randomization. So the investigators randomized the patients before the initiation of the preoperative chemotherapy. However, as I just mentioned, the difference of these two treatments were in the postoperative treatment phase. So why do you think that the authors didn't randomize the patients before the postoperative treatment? And what would be the pros and cons of randomizing patients before the preoperative treatment?
Yep. I saw the I saw this as a problem too, but I understood the randomization to be exactly as you have on your slides. However, the authors use the term perioperative. That is for the control arm. In one place, they use the term perioperative. Now, I understand what perioperative chemotherapy means, but they never used that term again. And I thought the randomization might have been appropriate earlier because they're using perioperative chemo. Does anybody think that the use of the term perioperative was a mistake there?
Yeah, I definitely did. It threw me for a loop. I had to go back and sort of reread that bit and then go back to how they described it, because I was a bit confused, at least from my understanding of perioperative. And then it was like, why? Yeah.
Right. Okay, good. Thank you.
Yeah, thank you. I just want to.
Yeah, I can add to that.
Yeah.
Hi.
Yeah, go ahead.
Maybe one of the implications of this randomization is the starting date, maybe the anchor date. It might impact how we take into account the death and the adverse events that happen during the surgery. If we push like for earlier randomization date, that might be tricky
Mhm.
when you try to interpret the results.
Yeah, that's a good point.
Or
Okay,
maybe
I
they-
just, yeah.
Oh, sorry. I was just thinking maybe when they're the randomization is earlier, they think that patients won't switch the group, because I can think when you had a pre-operative chemotherapy and then surgery, it's a long way. And then when you're thinking, oh God, I have to do it once more and I have to do radiotherapy on top, I can't manage it. Maybe they have the impression that more patients will drop off or change the group. So they decided just to lay the path in the beginning, hoping that the patients will stick to the regimen.
Yes, they said that randomizing early represents actual clinical practice when the decision is made early that they will eventually use post-operative chemoradiotherapy in one group. And there would be less patient selection. I think they anticipated there'd be pushback from the way they randomized, so they inserted that sentence to defend themselves. I don't think it was a good idea.
Okay, thank you to all of you. These are all very good points. So I just want to mention that the term perioperative in this concept, I think it includes both preoperative and postoperative. And just for maybe the simplicity, the authors just mention perioperative. So in terms of this point, yes, the authors think that by randomizing the patients before the preoperative treatment, it is more of reflecting the clinical practice because the treatment modality is usually determined at diagnosis before any initiation of any treatment. And it is based on the clinical stage, which is determined when the patient first gets diagnosed, and rather than the pathological stage, which is based on the surgical specimen after the surgery. And also this may avoid a selection bias. Yes.
Oh, sorry. Just occurred to me one point for the authors to do the before the after the surgery. Is that also possibly related to the dropout rate? Like if we do that post surgery, then maybe we might have a higher proportion of patients remain in the study after randomization. Just some thought.
Yes, that's actually the next point that I'm going to mention. So secondly, the authors believe that this may avoid a selection bias because those who agreed to or could start the post-operative treatment may differ from those who didn't agree or couldn't start. So by randomizing the patients at the very beginning, they will include all of the patients in the ITT analysis and will exclude no one because of these reasons in terms of the ITT analysis. So this is more of external validity issue. And another point is that these two different timings of a randomization may answer two different research questions, and they actually define two different study populations. If we randomize patients before the preoperative treatment, so the ITT population is actually those who started the perioperative treatment or the preoperative treatment. But if we randomize patients after the surgery, the ITT population would be those who started the post-operative treatment. So there is a subtle difference here. And also like Molly just mentioned, and I believe also Alexandra previous mentioned, the dropout and compliance issue. The randomization before the preoperative treatment is actually very early. So this may result in a high non-compliance and dropout rate. And also it does not allow a direct comparison of the post-operative treatments. Okay, so that's the end of this randomization and timing discussion. Okay, so this trial was a multi-center international trial. The authors used central randomization to conduct the randomization. And the randomization scheme they used was minimization, which is stratified by two important prognostic factors and the study site. Just a technical question, who can tell us what is minimization? In terms of doing the randomization.
If nobody else will jump in, it's sort of an advanced randomization technique where you basically change the probability of being assigned to one group to minimize the differences between groups according to certain characteristics of interest.
Yes, that's very accurate. Yeah, so it is basically a randomization approach that allocates treatment such that the imbalance between arms is minimized at the time. So it could be the imbalance of the total number of patients in each arms, or the imbalance of number of patients in the strata.
So what is the benefit of using minimization over just stratification?
Well, the minimization ensures the balance that you want. And also, we don't want to stratify by too many factors. I mean, stratifying by 5 factors, maybe stratify by 1 and use minimization to prevent the imbalance or minimize it. And they also point out that at the beginning, when minimization was first used, there was no random component. They just, if the imbalance was greater than 2 patients between these covariates in one arm and another, they just switched it. But now the switch is done where the switch is done with a probability of 95 or 98%. So there's still a possibility that it will remain the same. And that's because FDA had insisted that there be some element of randomization in the process.
Do you think, Jay, in your experience, does it ever kind of jeopardize treatment concealment prior to randomization?
No, I mean, you may know an operational way when it would, but in my experience, it didn't, because what happened when these is done by computer, the patient is randomized to treatment A, and there's no audit trail, at least there's no audit trail at the investigator site that that switch was made.
Okay, thank you both. Masking. So the authors mentioned that patients and investigators were not masked to treatment allocation. And this might be a reasonable approach, because in this trial, the investigators were also the physicians who treated the patients. So it was almost impossible to mask them. The physicians normally know that what kind of patients, what kind of treatment their patients receive. And also it was impractical to have sham radiation therapy because in terms of receiving this kind of treatment, patients needed to go to the radiation department and they needed to stand on these big machines and there will be noise, etc. So using sham radiation therapy would be impractical as well. But then the question comes, should outcome assessors be masked? And so this may not be very necessary in terms of the primary outcome, which is 5-year overall survival, defined as time from randomization to all-cause death. As we can see, this is an objective outcome, so which may not be that influenced by the awareness of the outcome assessors of the treatment allocation. But however, the unmasking of the outcome assessors may influence the assessment of the secondary endpoints, which include event-free survival, toxicity, and health-related quality of life. And I just want to mention that the first survival outcomes were used to evaluate the efficacy of the treatment, whether or not the patient lived longer. And the last two outcomes were about whether or not the patients lived better. So these 4 outcomes are kind of the standard set of outcomes used in clinical trials, oncological clinical trials, which I think is a nice feature of this study. Statistical considerations. Normally in this session, the first part is about sample size calculation. And here I put the parameters that the authors used to conduct the sample size calculation, including the overall survival in both arms, power, type 1 level, length of accrual, length of follow-up, and loss to follow-up rate. And the total number calculated was 788. Now, does anyone notice anything that might be unusual or raise your concerns in terms of the sample size calculation?
It's a pretty optimistic loss to follow-up, that they only lose 2%.
Yes, that's exactly the point. Yeah, we can see here the loss to follow-up rate is only 2%. And so in their calculation, they just took into account the loss to follow-up rate. They didn't take into account the non-adherence rate in the study. However, when we say dropout rate, I think it's normally includes both non-adherence and loss to follow-up. And if it is underestimated, there will be a risk of false negative results. If there will be a lot of patients who are lost to follow-up, then the ITT analysis might be underpowered as well. Even if the patients didn't drop out, they remain in the study, but the patients in the treatment group don't use the treatment, then we may observe an underestimated effect size. And there is a problem with overestimating dropout rate as well, mainly the ethical issues and economic concerns, because we would enroll too many patients in the study. And based on my limited previous experience, oncological trials, especially those phase 3 large trials, usually use 10 to 20% dropout rate, because the primary outcome is usually survival outcome, which involves a long term of follow-up. And yes, I think the authors were really optimistic in terms of the lost follow-up rate. Okay, so statistical analysis. Efficacy analysis of the survival outcome were conducted using the intention treat principle. Survival outcomes were analyzed by Kaplan-Meier method, log rank test, and proportional hazard Cox model. The authors also tested the proportional hazard assumption, which is good. They also conducted subgroup analysis, which takes into account the multiple testing issue, and also used the interaction test for homogeneity of the treatment effect, which I also believe are great practice. Now let's jump into the results section. So here is the analytic populations. As previously mentioned, there were a total of 788 patients enrolled. Approximately half were randomized to the perioperative CT group, and the other half was randomized to the pre-chemotherapy plus surgery plus post-operative chemoradiotherapy group. And those patients who were randomized consisted of the ITT population. However, as the trial goes on, patients started to drop out. Approximately 80% of patients in both groups completed the preoperative chemotherapy and underwent curative surgery. And until the post-operative phase, only 60% in both groups started the post-operative treatment, and approximately 50% in both groups completed the treatment. So the authors defined those who started a post-operative treatment as the PP per protocol population. And we can see there is a 40% difference in the number of patients between the ITT and the PP population. Okay, baseline characteristics in the ITT population. Here is the table 1 from the paper. We can see these variables listed well balanced between these two treatment arms, and we observe no p-values in table 1. Could anyone tell us why they didn't put p-values here?
Well, the difference isn't due to treatment. The difference is due purely to randomization, so that to put a p-value would be meaningless. That's why generally it's left out.
Yes, that's exactly the point. We would expect randomization, also not a guarantee, but we would expect it would balances the known and unknown confounders, and there is no point to do the statistical tests. And with statistical tests, we may get a significant p-value just by chance. Efficacy analysis of the survival outcomes in the ITT population. Here are the Kaplan-Meier curves of the two survival outcomes, and we could observe that for overall survival and event-free survival, the two curves of the two arms are overlapping all the way. And the authors got hazard ratios that's very close to 1, and also p-values very close to 1. So there was no significant difference observed between these two treatment arms in the ITT population. And so that survival analysis was one of the 2 places that the authors reported p-values. Another place that they reported p-value is this subgroup analysis, the p for interaction. So here we can observe that the P4 interaction for the variable of sex is significant which indicates that the effect is not homogeneous in males and in females. However, the hazard ratio within the subgroups, within males and females, both hazard ratios were not statistically significant. So there appears to be a contradictory result here. And how should we interpret this? Could anyone share their opinion?
We'd especially like to hear from students.
Should we say the treatment effect is homogeneous across the subgroups of sex?
Hi, this is Lin here. I think there's still some overlapping even within both sexes. So the strength of like the interaction may be limited, but even beyond that, it's still a secondary analysis. So yeah, we might have to take it with a grain of salt somehow. Yeah, it's suggested, but it's not confirmatory.
Is this commonly seen with chemotherapeutics? I'm not too familiar with this therapeutic area.
Do you say that again, Sharissa?
Sorry, is it commonly seen with chemotherapeutics? I'm not too familiar with this area.
You mean if
The difference across
like there is biological or medical like mechanism behind this
Yeah.
significant interaction?
Yeah, if there
Yeah.
definitely is.
Yeah, I think that's a very good point too. So yes, so like Lin mentioned, subgroup analysis may be underpowered because we divide the total sample size into small pieces. And this is just secondary analysis. And also, so if we do a lot of interaction tests, there may be a false positive in terms of the p-value. And then comes to Sharissa's point that I think this should be take into consideration whether or not this significant interaction has clinical meaning or can be backed by maybe biological mechanism. And the authors, so they did discuss this in their discussion session, and they mentioned that yes, we observed this significant interaction between sex and treatment group. However, they think the reason for this is unclear. So just for the purpose of comparison, in the second paper on the PB analysis, the authors did the same subgroup analysis. And here we can observe that the P4, so they didn't report the P4 interaction, but they mentioned this. So the P4 interaction for gender is no longer significant in the PP population. And they observed another significant P4 interaction in terms of the histological type, which may have clinical meaning. So yeah, so this subgroup analysis may not be very robust.
Shangji, your previous slide threw me also about that, the test for interaction, and you're noting that the confidence intervals didn't show a difference, but I think that has to do with the sensitivity of the interaction test. If you look at that, yeah, here we are. The P0012 is reflecting that, look, I have a hazard of 1 point in one group and 0.68 in the other group. They're opposite directions. That's what it's picking up. It doesn't imply that either one would be significant by that confidence interval. However, you'll notice that the edges are close to one in opposite directions, but the edges of the confidence intervals are close to including one. So I think that, or excluding one, I should say. But I think that's the reason for the interaction. We shouldn't spend much time looking at the individual hazards. As long as they're in opposite directions, that's what's being picked up by the interaction test.
Yes, I agree. I think we should look at the interaction tests instead of the individual stratum specific hazard ratios. Yeah. Thank you. Okay. Just to summarize at this point. So the study hypothesis was that the postoperative CRT improves overall survival as compared to postoperative chemotherapy. However, in the ITT analysis, the authors didn't find a significant result. The postoperative CRT does not improve overall survival as compared to postoperative chemo. So that concludes the first paper. And 2 years later, the authors published a second paper reporting their per protocol analysis results. And they also updated the length of survival from a previous of 5 years to approximately 7 years. And so again, so this is the analytic populations, and the ITT population consisted of all of the patients who were randomized, and the PB population is defined as the patients who actually started the post-operative treatment. And I just want to link back to the timing of the randomization. So here the PB population is actually those who started post-operative treatment. And I think if the authors had randomized the patients at this point after the surgery, then this would be our intention to treat analysis, and we may get different results. Of course, we want to look at the characteristics of the per protocol set by the treatment groups. Here, the authors actually reported the p-values of the comparison. And if we look at this table too, there is no statistical significant differences between the groups at alpha equals to 0.5 for all of these variables. And if we just eyeball these frequencies and the means of age, we can also observe no very apparent differences between the groups. So maybe we could say that at least in terms of this reported variables, the two groups might be comparable.
But
now let's look at, yeah.
Me, are they comparable? I mean, who drops out? You know, is that a select group of participants who, is there any difference in their characteristics? I don't think they reported that.
Yeah, that's a very important point. But the authors didn't give specific characteristics of the patients who dropped out. They did mention that, I will mention this later, they did mention age and cancer stage and maybe another variable were associated with the dropout. And they did report the survival outcome of these dropout patients, but they didn't report the detailed characteristics of this, of those who dropped out. The 40% patients who dropped out. Okay, so here is the updated result on the overall survival. The authors first reported the ITT analysis, and this Kaplan-Meier graph is very similar to what we just seen in the previous paper. They got a hazard ratio of 1.05, still very close to the null value, and a p-value that's not statistically significant. However, in the Kaplan-Meier of the PP population, we could see there is this consistent gap between the two treatment arms. And surprisingly, actually, it was the chemotherapy group that had better survival as compared to the chemoradiotherapy group. And of course, these curves are crude estimates. So the authors further did adjusted analysis. They did adjusted multivariable hazard, proportional hazard Cox regression, in which they adjust for all confounding variables, which were indicated with, which were in the table 2 that we just saw. And so they included all of these variables regardless whether they were there were significant difference between groups or not. And actually they got an adjusted hazard ratio of 1.62 and a very significant p-value comparing, sorry, there is a typo here, comparing CRT first to CT. So CRT group had a worse survival. So they used this adjusted multivariable regression to account for potential confounding. And they also use inverse probability weighting to account for the potential selection bias due to the differential attribution in the two groups. And again, they got similar results. So the chemotherapy group had a significant better overall survival as compared to the chemoradiotherapy group. And the hazard ratio was 1.5, so close to the adjusted hazard ratio in the multivariable analysis. And then just to summarize, so the study hypothesis is that CRT improves OS, and ITT analysis didn't find a significant result, and the PP analysis actually found a result that is contradictory to their hypothesis. Okay, so now let's get into the final discussion. Maybe we could take just a step back and start from maybe the definition of the ITT analysis. We know that the ITT analysis includes all randomized patients in the group to which they were randomized, regardless of their adherence or the treatment that they actually received. Could Anya tell us what does the ITT analysis estimate and what are the pros and cons of using ITT analysis?
So it estimates basically your sort of as randomized effect or your overall effect that you'd see being assigned to a treatment, as opposed to you know, maybe the effect of actually taking something. So it is more aligned with what you sort of see in practice in the real world. Cons are that, you know, it's not necessarily the best estimate for like efficacy of something, right? Because you are assigning people how they were randomized. So if you want to get the pure estimate of something works or not, then ITT isn't going to necessarily get you that if there's been a lot of crossing over, which I think is sort of what this shows and what, you know, we're going to be discussing, really how the PP is shows a difference because it gets at the people who actually then followed up and took took the assigned interventions.
Yes. So the ITT analysis estimated the effect of treatment assignment, and the pros, like Riaz mentioned, it is more reflecting the clinical practice, and it maintained the comparability of between groups and maintained the sample size. Also, it is considered as the standard analysis for clinical trials. And also, but however, it is conservative for a superiority trial because patients in the treatment group may not be perfectly adherent to the treatment, and we just include those patients into the analysis. And on contrary, per protocol analysis, kind of the opposite of the ITT analysis. So it includes the patients who were strictly adherent to the protocol. And so it estimated the effect of receiving the assigned treatment. And the pro is that some people would argue it estimates the true efficacy of an intervention because it evaluates those patients who completed the treatment. The cons, of course, like on the opposite of the ITT population, it does not represent the real world situation, because in real world, there is like no perfect adherence. Also, per protocol analysis usually has a smaller sample size and is likely to show an exaggerated treatment effect. And of course, it deviates from randomization and is susceptible to bias. Okay, so here are the results that we have seen before. And here I, like Dr. Holbrook mentioned before, so whether or not those who dropped out were similar to those who remained in the study, and the authors did provide some information in the discussion session, but they didn't show the exact result. So they mentioned that the analysis of the patients who did not start the post-operative treatment showed an opposite result. Those randomized to the CRT group actually had a better survival among those who dropped out. And also age and radicality of resection and pathological stage, cancer stage, were associated with dropout and of course the survival. So this is the additional information that the authors provide. And so what do you think, why the results differ and how should we interpret them? So we got a no result in the ITT analysis, and we got a result that this experimental group is actually had worse outcome, worse survival outcome as compared to the control. These are kind of seemingly contradictory results. If you are a clinician, would you give your patient post-operative radiotherapy?
I was going to say, or thought that the actual clinical trial and the ITT analysis, I think it is just a broken trial. You know, if people don't adhere to the treatment at that large percentages, I'm not sure that there's much that can be concluded about the comparability of the treatments.
Yeah. There was 40% dropout in this trial. which is, I would say it's a huge difference between the ITT and the PP population.
Yeah. So she asked about clinicians. I mean, the trick is that I agree the trial it has a significant problem, a substantial problem with this loss to follow-up, but the ITT shows no difference. The per protocol shows chemotherapy alone is better. Radiation therapy is not without side effects and not without effects on quality of life. It's this, what you have from both of these analyses is no evidence that chemoradiotherapy is any better than chemotherapy alone. Recognizing the problems with this trial, based with these data in hand, I think I would be hard pressed to design another trial to address the same issue, because your preliminary data suggests there's no benefit from chemotherapy, from radiotherapy. So yes, it's not a very good trial, but you know, even if you view it as a preliminary results for another trial, you'd be hard pressed to design another trial to answer the question.
I think that's a very nice takeaway of the result of this study.
Yeah.
Yeah, and I think just to add on to that, I think something they mentioned as well is just sort of that idea that even if there is a difference in effect, if the treatment's too demanding for everybody, right? So it's just such that everybody drops out, then, and you're not really seeing a difference in effect, then because everybody sort of drops out or can't handle the treatment, then you pick whichever one, I guess, whichever one the patient wants, probably, really, whichever one will have the lower risk of adverse effects, because overall people aren't going to be able to adhere. That's sort of how I see it, not as a clinician though, or sort of what I would imagine a clinician looks at it.
Yeah, but I take home a stronger result than that, just simply that. Radiation therapy is an additional treatment. It's expensive. It has morbidity associated with it, and you have no evidence for its benefit, regardless of how you look at these data, as flawed as they are. So in the bottom line, I see, based upon the data as they are, and as flawed as they are, no evidence that one should consider radiation therapy. I wouldn't recommend it. And I would say the real problem is that there is uncertainty as to the results because of the problems with the trial. But the flip side is as I said before, if you took these as preliminary data, you'd be hard pressed to design a trial, because your hypothesis would be that adding an additional morbid therapeutic intervention, expensive, is no benefit.
Yeah. Yeah, please go ahead.
Oh, I was just going to say, I was wondering if these results influenced clinical practice in the US, because isn't the North America?
Yeah, from my information, based on my information, I think radiotherapy is still like commonly used in gastric cancer patients in the US. It is not basically not used in Chinese gastric cancer patients, and one of the reasons is that, you know, this treatment is expensive, like Dr. Jacobs mentioned, and it's technically demanding too to the radiotherapists. So yeah, and the medical resources are also kind of limited. So there are patients with other tumors who may be, you know, may benefit more from this radiation therapy. and who are waited to receive the treatment. So in China, and I think in Japan, in South Korea, which are countries that have a high prevalence of gastric cancer, I think radiotherapy is not very commonly used. Probably in Europe as well.
Can I make a comment here?
Yeah, please. Yeah.
Yeah, sure. I think there are two clues that that is kind of blended in with your presentation that really got me thinking. One is the gender interaction term. Yeah, because in radiation oncology, when we do the dose prescriptions, men and women are like inherently different. Women, we have to think about their ovaries. We have to put that into the organs to protect. There might be some extra limits, like when we think about women in prescribing the doses. So I'd be interesting to actually see their dose graphs of those, like the radiation therapy they delivered. And also another thing is I noticed that the difference in the attrition rates between the two intervention groups. I think that might be kind of related to how like people getting different doses of the radiation, they might be lost to follow up at a different rate. That might be interesting also. And pertaining to your question here, the ITT and PP comparison, I think what Dr. Holbrook was mentioning makes sense. It might be just different population if you do the PP analysis. Yeah, they might have to come up with a way to reconciliate the two like study populations and try to compare and see their implication for their conclusions.
Yeah, thank you. I think in terms of the dosage of radiation, so the PP population just included all of the patients who started the radiation therapy, regardless, like the actually dose they received. Yeah, and so in terms of the comparison of the ITT and PP analysis, here I just put some methodological points. As they may there still be unmeasured confounding or selection bias because the authors could only account for the observed variables. And again, like you just mentioned, so the ITT and PP analysis, they answer different research questions and look at different study populations. Yeah, ITT would be still, I think, the standard analysis of a clinical trial. Yeah, and I think I went a little bit over time. That would be all of my presentation today. But if anyone else who has something to share.
Yeah, I might just say that nowadays there's a big emphasis on estimands in clinical trials, and these especially occur because of the concern of intercurrent events. And so there are different endpoints that people are advocating besides ITT and PP, and that would be a composite endpoint where certainly the dropout is a intercurrent event. So that what we might do in an overall survival analysis is count the dropouts as deaths, and even though they're not. And that's a composite way of analyzing, which shows that the dropout was a certain kind of failure, and there'd be controversies of that. I mean, if someone drops out because they moved to another city, you wouldn't want to count them as a death. But anyway, that's what people are doing. I just want to point that out. I'm not an advocate necessarily for any of this.
Yeah, thank you for mentioning that. I think it's very interesting and I will look into it.
Okay.
If I can also make just a sort of unrelated plug for something, if the presentation's done. Tianjing has organized a sort of method symposium that has 3 sessions. She sent out, emails pretty far and wide. I can also send sort of the poster out again to Lynn and Iman to send to the group if people haven't already registered or would be interested. But it's a method symposium for systematic reviews and meta-analyses. The first one was this week, sort of talking about complexity in systematic reviews. Next week is the second session, talking about sort of automation and machine learning and things in systematic reviews coming up. And then the third session is in the start of March, and I'm going to be presenting in that one some of the stuff on synthesizing harms and systematic reviews. So I'd recommend it. The first session was great. I expect the other 2 will be fantastic as well. Something if you're interested in, that.
Thanks, Riaz. I also have another announcement. Shinji, that was a great presentation. Thanks for going
Really
over
good.
it so comprehensively. We do have one date that does not have a student assigned, May 13th with Dr. Herson. So if anyone would like to take that one, we can gladly put your name on it. Otherwise, I might go ahead and assign 2 students so you guys can split the work a little bit.
For a journal club?
For journal club, yeah.
If it's probably like the last one, right, of the year, I'd take it for fun.
Okay.
I've always wanted to do one specifically for fun. So it would be a good example.
All right. And Dr.
If you're
Herson,
working with me, it won't be fun.
I was just saying the opposite.
Might.
All right, y'all.
Well, I'll run it by you. We'll get in touch.
Okay.
Thank you, Riaz, and Dr. Herson, thank you. Take care.
Okay.
Bye, everyone.
Thank you.
Thank you. Take care.
Thanks. Bye-bye.